Today we are discussing the intubation procedure. So prior intubation, we should make sure that we are in aseptic condition. We should wash our hands. We should be prepared, and then put a gown using a gown, and then we should use surgical gloves and a face shield and a face mask. So after preparing this, we should prepare the patient. So before doing intubation, we should make sure that patient is connected to monitor, and it's a cardiac monitor. It should be a cardiac monitor, and we should monitor his vitals prior intubation. So prior intubation, main things we have to check is bougie, laryngoscope, and ambu. Ambu we should see whether it is in working condition. It should be connected to the oxygen. So after checking this, we will sedate the patient by giving the medication. So sedations can be given with midazolam or propofol, whatever the indication is there for the intubation. Prior intubation, prior sedating the patient, we should make sure that we have the emergency medications in hand. So during sedation, there will be a chance of cardiac arrest. So that we should keep atropine and adrenaline loaded for any chance of cardiac arrest. We should be prepared. Okay, so once you keep it loaded, then we should make sure that we use sedations on the indicated patient only. Okay, so generally we use midazolam and propofol. So these are the sedations used, and we can also use scoline. Yeah, scoline can also be used. Okay, so scoline completely relaxes the intercostal muscles. So once the sedation is given, we should wait for the patient to get sedated. We should not immediately start intubation once you give the sedation medicine. So once you give the sedation medication, we should start with the pre-oxygenation. So we should make sure that patient is highly oxygenated, so that once you start intubation, we will have some time to take. Okay, so by doing ambu, we should oxygenate the patient prior intubation, so that while doing the ambu, while the patient gets oxygenated, patient also gets sedated at the same time. Okay, once the patient is sedated, then we'll use the laryngoscope. So by using the laryngoscope, we also should make sure that we have the suction inside. Before intubating or before using the laryngoscope, the bulb should be made sure it is lighting. Okay, so once we check the laryngoscope, we put the laryngoscope on the right lateral section, and we make sure that tongue comes behind the laryngoscope blade. So we proceed slowly into the oral cavity with the laryngoscope. So we should also make sure that we have a suction. So the suction tube should be connected to the suction, and we have a suction catheter connected to the vacuum suction. So we should make sure after putting the laryngoscope, we do suction, so that there is no any residue or whatever the fluids, or if there is any bleeding, we should make sure that the cavity, while passing the laryngoscope, the cavity should be clean and it should be visible. We do suction for visible purpose, for our vision. Okay, so once the blade is passed till the glottis, so we lift the chin by using the handle. Throughout the process of the intubation, we should never leave our handle. So one's hand should never leave the handle during the process of intubation. So you should hold it tight. So once you put it, and we should make sure that we see the trachea after reaching the epiglottis or glottis, whatever we lift it. So once we lift the chin, we find the trachea behind the glottis. Okay. So once we see the trachea, we can clearly visualize the trachea by its movements. Inflow and outflow of the air can be seen through the larynx and the trachea. So we shouldn't intubate, or we shouldn't put bougie or anything without visualizing the trachea. So once you visualize the trachea, we put the bougie into the trachea. So the tube, the scope should be in hand, and bougie into the trachea. Then we will take the tube with the nursing assistance. We take the tube and put into the bougie. So once the tube is completely pushed down, we should hold the bougie. Then with the we should make sure that tube passes through this line of the blade. Okay, so we can slowly push having the blade inside, so that we can push the tube. We slowly push the tube through this end, and once it enters the trachea, the body will give a jerking movement. It's a response from the brain. So once the tube is inserted, we can remove the bougie. We should make sure that tube is in right place or not. Once by seeing the tube internal lining, there will be a fog formation inside the tube. Okay, that is one confirmation. Later on, we should see the we should connect the ambu and do the ambu. So we meanwhile in the same process, we should make sure that patient vitals are maintained. Okay, once the tube is done, once we put the tube, we should take off the mask and connect the ET. Inside, we check the airway. So we can connect it here, and we do ambu. So by doing ambu, you will find me a fog formation inside the tube. So once the fog is formed, we should also do auscultation using the stethoscope, so that we make sure that airway is clear and lung expansion is even on both sides of the lung, and air passes evenly on both sides of the lungs. We should hear the sounds clearly. Main problem is if tube is in not in correct place, only one lungs gets the airway or air from the ventilator or the ambu, the other lung gets consolidated or collapses. So this is the main complication of the intubation. You have to make sure that tube is in the correct position, so that lung or the rib cage expands evenly. So both sides of the lung should be seen and ausculted properly. So once you see that airway, you should fix the tube. The markings are here on the ET. So 18, 19, 20. Based on the markings, wherever you feel the airway is clear, you can fix the tube. Generally, we do it in 19 to 22 or 20, wherever the possible airway is clear. When you make sure that airway is even on both bilateral air entry is clear and even, you can fix the tube. So once you fix the tube, fixing the tube is what we mean is we inflate the balloon of the ET, so that it gets fixed inside at that place. So we fix it in the mouth level. These readings should be at the mouth level. So fixing in the sense, we fix it in the mouth level or teeth level. It should be between 90 to 22 when wherever the airway entry is free and clear. So after fixing the tube, we use this gauze thread to tie the tube around the patient. We use it like this. So this is the ET. So we tie it like this, and we should make sure that this is visible and it is along with the tube. So first knot we put it like this. There are two ends. So one end you take one side of the patient's mouth, and the other side you take it the laterally. So after putting the tube and after tying this, we should put the airway. So we should open the airway and put it inside the tube, inside the mouth, so that prevents biting of the patient with the tube. So again you can do suction also. If there is any secretions or any fluid is there inside the tube, you can do suction from here. Okay. So once the mouthpiece is placed, airway is placed, and you can fix the tube using the knots and the dynaplast. And you should make sure that dynaplast is cut in 2 or 3 pieces in this pattern. So once the tube is fixed, you can do this. Can be connected to ambu here like this. Once doing ambu, once we achieve the required amount of saturation, once the airway is done, once we secure the airway, so that we can connect it to the ventilator circuit. So this circuit can be connected over cath mount. So once the intubation is done, we connect the ETN to the cath mount here, and this cath mount is connected to the circuit, and circuit should have a filter. We are connecting to this, so we connect it like this, and we turn on the ventilator so that it works inside the nut. And we should anyway, there is a different video on the ventilator which had been added to our channel. Please watch that for the ventilator settings and all.